You're listening to the We Are Libertarians podcast network. Find all of our shows at wearelibertarians.com.
Episode 173, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format through expert analysis. Today's going to be a different episode. I haven't done one in a while. I've been very busy with my other podcasts, but I wanted to just do it live, present an opportunity for people to feedback or kind of watch it. But we're going to talk about an episode that I'll title just as It's Over, because our president declared the pandemic over. I think it's time just to look at what's been going on, look at what we've talked about in the show for over 2 years now. I've tried not to focus much on COVID, especially last year, because it's kind of annoying, but also along those same lines, it's been really annoying. And I think it's something that just kind of get off my chest. And so that's what we're going to do today. We're just going to kind of go through all of COVID, what's been going on, where we are, where we should be, and I think just have a better idea, because things are just broken. And so let's just begin. I've made some notes to try and make sure I encompass everything here. Let's begin first what COVID is. COVID-19 is actually a disease caused by SARS-CoV-2. SARS-CoV-2 is the coronavirus, and it's the second one. The first SARS-1 is the original SARS, the OG, right? The one that swept through Asia and Canada in some respects and some parts of Europe. Caused a lot of problems, got people really sick, and it did not spread much. It was contained very easily because it was a different type of virus than SARS-CoV-2. SARS-CoV-2 was easily transmitted. You're transmitted even before you showed signs, oftentimes, and so it could spread quickly, very easily. And if you've never had exposure to it, which of course no one had, because you're basically naive from an immunological standpoint, you could get really sick, especially if you're elderly. I mean, that was clear very early on, and we're talking early 2020 in February and March. We knew that it was the people most at risk were those who are the elderly. And certainly people with comorbidities, people who are sicker, who have metabolic disease, like people who are obese or people with hypertension, heart disease, those sorts of things, they were at higher risk for problems. And so that's sort of the backdrop of when it began. It's important to remember we don't know exactly where it began, whether it was actually zoonotic, meaning it started in animals, or whether it started in a lab, which is, in Wuhan, which is obviously one of the theories. It's initially, I think, there's evidence that suggests that it was from the lab, because they were experimenting on viruses, especially coronaviruses that they acquired from bats. Is that where it came from? Not sure. I think there's reasonable evidence that you could make a surmise that it possibly was, but it doesn't really matter. It matters, but it doesn't matter in the light of our discussion today, because we're just going to talk about the disease. So once you get infected with the coronavirus, it can cause an immune response from your body. It can cause an upper respiratory tract infection, which is usually what people get. That's like a cold, right? So that's runny nose. Maybe you lose your sense of taste or smell. You can get coughing and those sorts of upper respiratory symptoms. What was especially bad with SARS-CoV-2 is it oftentimes became a lower respiratory tract infection where it gets in your lungs, can cause pneumonia, and sort of a host of all sorts of other problems. And then when you get a really bad infection, pneumonia, other parts of your body can, with the immune cascade, you can get other sorts of symptoms and problems. And that's, where oftentimes caused fatalities and significant morbidity. So the one thing I think is there are a number of things that with this that's really hard to put your head around, because at some point this became a political issue and it became a political disease, and there were two sides, and there are never two sides. It's never been the way we've been in the show. It's been a nuanced show. I like to think that I like to look at both sides. I obviously have inclinations towards one way or the other, but I think it's important to recognize that someone is not always right, someone's not always wrong. There's probably somewhere in between. There's a gray area, and one could say that this is a very deadly disease, when you're immunologically naive, meaning you've never been exposed, you have no prior immune response because of vaccination or something like that. That's a very different situation than someone who is been exposed, been vaccinated, and now maybe, it's different. Also, if you're young or old, healthy or unhealthy, lucky and unlucky, right? That's always part of the case with any sort of disease or problem, trauma, certainly everything. You can be lucky or unlucky. You can step off. I can't tell you how many people I've taken care of in my practice who've done things that are ordinary, and for whatever reason they break their ankle, like they step down one step the wrong way, right? And whatever that means. They jump down from a 2-foot wall, and you probably could do it 1,000 times and be fine, and then that one time that I see you is when you've broken your ankle or twisted or something like that. Same thing can happen with infectious diseases. You can be exposed to something many times, totally normal course, and then for whatever reason, one time, or maybe your genetics are wrong, or something else about a recent infection, perhaps some medication you're on, something that's set you up for some reason to be more at risk for a serious complication or potentially death. We don't know understand a lot of that stuff. They happen at the small levels. And again, it's sort of like cancer. You get exposed to radiation. Some people get cancer. Some people don't. Don't know why. It just is. That's just the way things happen. But that all aside, there are certain things that we knew about SARS-CoV-2. And I'd say that as someone who didn't know anything about it. I mean, as an anesthesiologist, I certainly don't know a lot about. I don't pretend to know and be an expert in immunology or infectious diseases. I talk to people who are, and that's where I get my knowledge. And so when I talked to Dr. David Graham way back in April of 2020, he presented a pretty grim picture of this pandemic that was going to come. He said, this is a highly infectious disease. It's going to affect you multiple times throughout your life. Most likely what's going to happen, it'll be like the other 4 coronaviruses that are circulated within human beings. It'll be the 5th, and it'll be endemic, which means it'll always be present. It'll always be changing slightly. You're going to get infected multiple times. Probably, not for sure, but probably it's going to be the worst the first time you get it. Every time you get after that will probably not be quite as bad. Now, of course, that means, as with anything with nuance, sometimes the second or third time might be worse than the first time. But generally speaking, the disease, the fatality rate, the sort of morbidity rate will lessen over time. Probably not so much with a change in the virus in the sense that the virus gets weaker, although that does also happen over time, but probably more just in the fact that your immune system recognizes enough that it does not freak out, for lack of a better term, and when it's exposed to it. And so it won't get you as sick, and it won't cause as much of a lower respiratory infection, and it'll just be able to hold it in check so that it just becomes an upper infection. This doesn't mean that you have massive circulating antibodies for SARS-CoV-2. Now, you do initially after infection of anything, but those antibodies wane. They have to. That's how your immune system is designed. So measuring antibodies and the antibody levels is sort of determining how immune you are from something is probably not terribly helpful because, of course, if that's all you had to have all the time, then you've been exposed to so many viruses and so many pathogens through your life. You couldn't have that many antibodies circulating to give you sterilizing immunity usually. And so if that's the case, because your blood would be like molasses, wouldn't work. So your body has this sort of mechanism where it has memory cells. It remembers like, hey, I've seen this before, and it can easily ramp up real quickly. If it's a novel virus it's never seen before, it takes a while to get that immune response. And for some people, and I think this is probably the case, especially if you're elderly, for whatever reason, you just weren't able to mount the immune response soon enough to actually get better. And do kids have some sort of inherent extra plasticity and that they're better with these upper respiratory infections like adenovirus, rhinovirus, coronaviruses? I don't know. Maybe. And that's why they don't get as sick. That's probably the case. But how exactly that is, we're not sure. I don't think we exactly know the mechanism. But anyone who's had a small child or raised kids, you know that they're sick all the time when they're little. I mean, they're getting 3, 4, 5 colds every year. And those colds are just different viruses. And that's just part of the normal, thing of growing up. Most of the time, it's just a cold. On super rare occasions, it can cause worse problems. And I think in general, it's pretty indisputable that SARS-CoV-2, this coronavirus, is worse than most common colds. And now maybe that's because it's new. And like I said, it hasn't quite evolved so that it's not quite as lethal. That tends to be the course of most viruses. They get to get a little less lethal, especially these upper respiratory infections. Maybe that's part of it. Maybe, I'm not sure. But I think the fact of the matter is it's just not that dangerous to kids. We knew this in April of 2022. We knew, and looking at what's happening in China, despite all the people freaking out, all the things going on, it was clearly not as dangerous to children, to people who are younger. And it was definitely more dangerous to people who are older, the elderly. That was clear in the cruise ship data, and I think when that's like it went through, just like I think an aircraft carrier in the U.S. fleet, it went ripped through that fleet, and the people who got the most sick generally were older people. So that's the backdrop. And so I think the key things to remember is it's going to be around forever. You're going to get it multiple times. There are long-term and short-term consequences for it, but long-term, I think you just need to look at this virus differently than in the short term. So we've exited the short-term portion of the infection. Is this a pandemic? I mean, endemic, it's hard to know if you look at the various definitions. An epidemic could be any sort of virus that comes to your community. It has high levels of infection. It gets a lot of people infected, and then it kind of goes away. Pandemic just means there's an epidemic in multiple places. So I don't know exactly the definition, but from a resource standpoint, what it's doing to the hospital systems and the public and how the actual burden of disease and morbidity and mortality that's causing, it clearly is not what it was 2 years ago. I mean, I don't even know that's disputable. And so the other thing we can look at too with SARS-CoV-2 is it is evolving. It is changing. There are different variants coming all the time. That's normal. That's what we would expect. But also, because it's changing, we can't have a perfect immune response to this virus. Even you can, some viruses, once you've seen it once, you can never get it again, but it's probably not the case with the coronavirus because like I said, you're not going to have enough sterilizing antibodies that you can have in your upper respiratory tract that are going to prevent you from getting it, prevent you from getting really sick. Since it's changing all the time, it's going to be harder to have a perfect immune response. What will happen is it'll just basically be what we call a cold. We don't actually, we rarely test to see what kind of virus you have. If you go to the doctor's office and you have a cold, it's not a bacterial infection where you got like sinusitis or something like that, where antibiotics don't work, you don't really care what kind of cold it is. You don't care if it's a rhinovirus, a parainfluenza virus, a rhinovirus, another coronavirus. You don't care because the treatment's the same. Rest, stay away from other people, don't get them sick, hydrate yourself, those sorts of things. It's just, you'll get over it. And that's sort of that's your body, that's how it's designed to get through the environment. So all that being said, SARS-CoV-2 is going to be around for a long time. You're going to get infected multiple times. No matter how many times you're vaccinated, it's going to happen. And we'll go into that a little bit further. But also, before I go any further, I just want to disclose that I am running for the University of Michigan Board of Regents this year, statewide race. I'm recording this on October 3rd, 2022. So this election's first in November, I think like the 4th or something like that. I'm running as Libertarian, so just as full disclosure, anyone in the state of Michigan should certainly vote for me. Anything I'm talking about is, I don't know, it's like election or campaign sort of material, but I guess just disclose that for what it's worth. So right now, there are a lot of things bugging me. So one is the world is full of grifters and it's full of charlatans. I am stunned, but probably shouldn't be, that there's so many people who are going out of their way to make money or to get fame, notoriety using COVID, like either as an alarmist or I'll say minimalist. So like COVIDians, the anti-COVIDians, I don't know exactly what the terms are. People who are totally freaked out about COVID all the time, and they push as hard as they can that it is the end of the world. And those who are insistent that everything those people say is 100% wrong. And I like to point out that we do nuance the show. We actually try and look at what's right and wrong. And there's some things that are just impossible to know what's right and wrong. And that's just, the world is a matter of gray, and you can't sometimes know like what the right policy is, what the right medication to give someone is. It changes. But the key is, I think, is knowing that there are people who are capitalizing on this, on fear, anxiety, anger, whatever it might be, or people are angry at being afraid, and people pushing the panic. And just recognize these people for who they are. there's some people who are trying to cut through it, and they're certainly on one side or the other a little bit more than the others. And again, I hate saying sides because I feel like it's a virus. It doesn't have sides. The virus doesn't care who you are. It just cares that you're, Homo sapiens, right? Like it can infect you. But looking at it from a political standpoint, I guess, or I don't know exactly what the standpoint is, but the fact you clearly know what I mean. There are people who are alarmists and people who are minimalists. There's probably some truth somewhere in there. I think probably there was more alarmism early, which was maybe more appropriate because people hadn't been infected yet. Now we are moving away from that. Now it should be more minimalist people, like recognizing that the reality of what COVID is, what it's going to be in the future, and what you can actually do, right? So I think once you have people vaccinated, et cetera, or haven't had a prior infection, they have some immunity built up, you're kind of about as good as you can get. But it's caused a lot of problems with science. Media certainly inflamed this, but science has gotten broken. We're not able to discuss things. We just see recently California passed a bill to prevent doctors from, they'll take their medical license away if they provide misinformation, whatever that means. It's not clear. And because I guess it's just defined by the medical board. I don't know. I mean, I think it's a chilling effect. I think lots of doctors should be allowed to give bad opinions and bad advice. There's a malpractice system if you're way outside the bounds of things that are dangerous. That's what sort of keeps you in line as a physician. But there's just a lot of latitude in how you treat people and how you approach disease processes or, whatever. And it's concerning to me if that would be in that sort of First Amendment principles, or certainly the doctor-patient relationship, is hurt in any way. Obviously, there are other restrictions on speech that are reasonable, like commercial speech, and there's speech on sort of platforms that can sort of do what they want since they're private. I get that. I get your employer might want you to do a certain thing. I understand those things, and that's different than the state taking away your ability to earn a living. Now, I guess if you're a hardcore libertarian, you're like, well, you offered to let them license you, whether you can or can't do things, so you should have to play by the rules. But I think, we should, as a principle, allow people to have latitude in discussion, because the problem is that as we stifle speech, you're not getting rid of it, right? I mean, still the people who have crazy notions about COVID, making people infertile, or the vaccine certainly, they're still going to have their opinions. If you suppress it, there's going to be sort of concerns like, why are you suppressing it? Well, clearly there must be some truth behind it, right? Those people still have they'll still have their followers. They'll still have that message getting out. So you can't suppress bad thought. The best thing you can do is you can approach it and have a civilized discussion. What should have happened with COVID early on is we should have been discussing trade-offs. We should have been discussing the science. We should have been looking at these things. And the places that you do that are the academic institutions. Those are the places where you say, all right, let's get a bunch of people sitting together. Let's hash through these things. Maybe some people are bad, they're bad explaining things, or they're coming with poor arguments, or they're coming with lies, or whatever. But those can all get flushed out when it comes to the academics. I mean, you might bring 20 abstracts and say, well, see, all the preprints are showing this. Well, those are preprints. Those haven't been peer reviewed. Even the peer review things, they have to be replicated, right? I mean, just because you had one study that proves one thing, no one would think that that's adequate evidence that something does or doesn't work. I mean, that's not the way the scientific method works. And so that's important that we should have that. So that part has broken science. It has broken our discourse. And because science and then media, and then I think the politicians latch on to this, they've all worked together to obviously make it a very challenging environment for us to be productive and sort of find the truth, whatever the truth means. But certainly when you want to try and find good treatment options, when you have good preventative options, how do you find those, and how much should your level of concern be for these sorts of things? And so without this discourse, honest discourse, it's been a Achilles heel. It's really hampered our ability to get through this COVID. And so that leads us to, what, of course, the corollary of that, or I guess part of the problem with this, is the government agencies are also really broken right now. And those are obviously, I mean, the FDA, the CDC, I guess you'd say NIAID, that's when Fauci ran. It's very politicized. Now, obviously, government agency, by its very existence, is political. You might say, oh, well, they're based on science, or it's whatever, but clearly it's not. And because if it's part of the political unit of government, it has to be by its nature political. It's going to make decisions that are not always that are influenced at least by politics, by the people who make decisions, and that's the executive branch. And people in the executive branch appoint people in those positions. Now, sometimes they don't change those people who are there. If that's the case, then you would expect it not to be very differing as far as its political trajectory goes. But clearly, the CDC and FDA have, and their leaders, Surgeon General throw in there too, and then obviously all the White House and everything, this has all been a very political sort of disease, which is really weird. But it has also been very challenging to get to the truth and to find policies that make sense. It has created a top-down approach to battling this virus. I mean, we have a federal system in this country so that governors can sort of push back on parts of it, but they're not always effective. And so that's been a challenge as well. Hopefully, we're getting to a point where that's not going to be as much the case, but it still feels like it's very much the case. And of course, the problem is the CDC and the FDA are governing bodies for medication releases and for recommendations for health, for pandemics, for instance, for the CDC especially. And so when they're having trouble being apolitical and sort of just providing the evidence as we know, or providing shoddy evidence, which has been more of what's happened recently, it erodes your trust. It, of course, makes it difficult to have things that are pretty well established to be able to have credibility when you speak of those things. And we've definitely seen that breakdown with the FDA and the CDC. And the fact that it's so coordinated, I think, has been another big problem with that they are lockstep with each other. It doesn't seem credible, right? I think that's part of the problem with the fact that you don't have any differing opinions, really, at least that are obvious to the public, or to someone like me in medicine. So you feel you have a very top-down, sort of monolithic sort of response, and that doesn't seem very reasonable. So it definitely feels like it's phony, and I think that's been a real problem. And when things have been proven wrong, there's no apologizing. There's no like, oh, we were wrong. It was just like, oh, well, we always knew that. And so there's a little bit of like gaslighting, which is, I think, really challenging to maintain a credibility. And it's going to have, well, as we'll discuss later, it's going to have some real long downstream effects that are going to be long lasting, that are going to be a real problem. So let's talk about mandates, which drive me kind of crazy. First of all, masking mandates. Most places don't have mask mandates anymore. I think when you look at the evidence for masking in general, the efficacy, which means how well it works, is very dubious in the public. So there are two different types of experiments you do in science. There's in vitro, which means you do it like in a lab, like in a petri dish. And there's in vivo, where you see what something happens in real life, right? So you can say, if we make the speed limit 35 miles an hour, if we put a speed limit sign that says 35 miles an hour on the street, that everyone will travel 35 miles an hour. Well, you and I know that, in vitro, in a lab, you could sure make an experiment where you show everyone's driving 35. You're like, yeah, this works. It's a great idea. But in reality, people are going to drive 25. People are going to drive 55. And so what happens when the real world meets the science? So whatever your experiment is set up that you were going to do at one thing, well, that doesn't mean that's not how most people are. I mean, you have to recognize that the world is a complicated, messy place, and people do things the wrong way. They do things intentionally the wrong way. Some people are just confused. I wear my mask inside out, upside down, below my nose, above my nose, over my chin, under my chin, not over my chin, not my mouth exposed, or whatever. I mean, when it comes to masking, I'm just getting the public to understand how to do it. You would think it's obvious, but it's not. Like anything, there's certain things that are obvious and some things aren't. So that has been a real problem, and it's made it so any sort of mask, mandate you have to recognize that it has to be something that people could follow. You ask someone to do something for extraordinary long lengths of time or in extraordinary measures or things that are incredibly uncomfortable or whatever, like having high school athletes play basketball or volleyball or something like that with a mask on. That is not a reasonable expectation. One is you don't know the efficacy of using a mask, how well it works. When someone's running up and down the court, breathing really hard, is that mask as effective as it is on your dummy in your lab when it's just breathing like a normal respiratory rate or whatever? My guess is probably not. The other thing is the types of masks that are, most people are not wearing surgical masks. And I would tell you, as someone who works in the OR all the time, surgical masks are not designed to prevent aerosolized viruses or infections. Sure, I think you put anything in front of your face, it's going to have probably decreased incidence of getting some things in your respiratory tract. I put a piece of cloth in front of my face. And sure, I've got a couple of 2-3 ply surgical masks. It's going to be more effective. But the reason we wear surgical masks in the OR is not for infection control. Really, it's mainly just for droplet protection for the patient. If I sneeze, I don't spew droplets of stuff everywhere. Or if there's a splatter, it doesn't get into my mouth and my nose. I mean, that's why we wear masks. It's not for infectious control. If someone actually had active tuberculosis, no one's wearing a surgical mask thinking, well, I'm safe. I got a surgical mask. You'd have to put on N95, a fitted N95 where you have a good seal, you have good no ventilation leakage around from above or below, so you can't have a beard, all sorts of things like that. And so the expectation to get people to wear a regular mask, like a cloth mask or a surgical mask properly everywhere all the time is, I think, not great. And then if you try and add to that, well, so now you have to wear an N95 where it has to be fitted and has to have a good seal. Well, the likelihood of getting the public to, if you manage to do that, and they could actually wear it properly, then it probably would have a significant effect on things. But that would go back to our previous point, which is, if everyone did that, would you prevent infections of SARS-CoV-2? And the answer would be no, because at some point, people are going to take them off when they go home. They got to eat their hamburger, or they got to, drink something during the day. I mean, they can go, I suppose, 8 to 10, 12 hours without eating or drinking anything. It's possible. But it's unreasonable to expect anyone to wear that long at all times, because, we need to see faces. We're human beings. And so anyway, the mask mandates for that reason were doomed to fail for practical reasons, for practical purposes. There's no way you can expect people to wear masks, certainly not for more than a couple weeks. I mean, that's, I think, extraordinary. And then the fact they can't wear the right masks. And I would say, even if you wear the right masks, the next question is, how long do you have to wear them? Well, if you say, well, until SARS-CoV-2 goes away, we already established that it's here forever. So if you've accepted the fact that you're going to wear an N95 the rest of your life, I suppose, and anytime you're in public, I suppose you can live life that way, but you have to wear it forever. And you can say, well, we're just going to wear it when the infection rates are low. Well, they're going to only be low until you stop wearing the mask. Then as soon as you don't, all those people are immunologically naive, and they will get infected with whatever the new variant is of SARS-CoV-2, and so you'll start a quick outbreak. You can quickly pivot and say, well, now tomorrow everyone's got to wear a mask, but how are you going to communicate this to everybody? It's a pretty much impossible sort of thing to expect for anyone to do. So there's no way that a mask mandate could work realistically for any long extended period of time. One, training. I mean, we can't even train everybody to know how to do CPR, which is, without a doubt, a huge public health benefit to maintain people, who've got a cardiac arrest. And we can't even train everyone to do that much. There's no reason to think that, there's no way you can think they're going to have resources to get masks and wear them properly and all the time. I just don't see how it's even like something you should consider. Also, I think you look at the studies, most studies with regular masks or surgical masks don't show a whole lot of effect. In fact, they've been pretty ambiguous as far as the results, which is what you'd expect. I think it'd be pretty much like anything else, that it's going to have a marginal to no effect. And so will it affect things a little bit? Sure, maybe a little, but probably more than anything, it's going to impede other things in your life. And so I don't know. I mean, I think it's highly unlikely that a mask would work if you're like a regular mask for an aerosolized virus. Now, initially, maybe we didn't know for sure it was a droplet transmission, then a mask would work much better. But as soon as you know it's aerosolized, I mean, you basically are saying you're not going to have any air get to you for the most part, right? Unless it's like highly filtered. The surgical masks, there's no way they could work. So it's never made any sense to me. And I think, when you look at, so then the question is, do you need them in the hospital? And so most people where I am in West Michigan, no one wears masks anywhere. And which is fine. I think it's totally reasonable, and I don't either. But I have to wear masks in healthcare settings because that's the recommendation from the CDC, and lots of the hospital systems insist on it. I'm not sure what the hospital is hoping to accomplish for this. This is not unique to Michigan. This is most places that I'm aware of. The healthcare settings are seen as different. Well, because patients are vulnerable, they're sick. I totally get that. It's totally understandable. But for one thing, is it really preventing a whole lot for an aerosolized virus? I think the evidence is pretty weak that it's doing much. So then the question is, how long do you do it? Are there any trade-offs to this? So I could wear a hazmat suit at work all day long. We could expect everyone to wear hazmat suits. And we know for sure the transmission of things would be a lot less, right? For viruses and bacteria, et cetera. But what's the cost of wearing that? I mean, it's expensive. I'm saddened every time I leave the hospital. I just see trash cans full of just these masks. And those are the ones making the trash can. The other ones are like strewn in the parking lot. They're in the ramp. They're all over the place, right? People litter or accidentally falls in their pocket or whatever. So that's just a tremendous waste just for landfills and stuff. I mean, and you have to buy them, you have to produce them. It's just a waste for something that I think doesn't provide any benefit. So then let's say you're going to wear it for in the hospital. Well, what are the other trade-offs? Well, I can't communicate as well with patients. They can't understand me as well. Is that important? Well, I don't know. Do you think it's important to know what your doctor is saying or your nurse is saying? Is it important to see someone's face? Is there some sort of cost to not seeing people's smiling face or whatever it might be? Well, there's probably, a benefit to that, right? That's kind of why we're designed with faces. So anyway, I think if you're not significantly decreasing the viral load from wearing masks, I don't see what the point of it is. Now, if someone's immunocompromised to the point where they're like bone marrow transplant patient, then we've always masked up. If someone's got tuberculosis, we always put a mask on and then we leave the room and we take the mask off. Those are prudent measures. But to wear one 24 hours or, whenever you're on shift, I think it's real questionable. I think you have to have a real good reason and you have to have really good evidence that it's something useful. And I just don't think it's there. Now, you could say, well, it's no big deal. You just wear it. But I have people I worked with for 2+ years. I've not seen their faces. I don't really know what they look like. I mean, I know what their eyes look like. But it's always hard enough for me when I see someone in the wild, my coworkers, because I'm in the OR, and I say, I didn't know you had hair down to your waist, or it's, you've got red hair or something like that. So I think, that alone is a challenge. I just think we have to really ask ourselves why we're doing it and if it's useful. Then let's look at lockdowns. I think we can just pretty much discuss, or just sort of just push them out of hand, that the lockdowns and the measures to prevent the spread of the virus, although it lowered it slightly probably if you just limit social and interaction, it's only delaying what's going to happen later. And so it didn't really change anything. It didn't flatten the curve significantly. We still had massive viral loads all the time and hit the hospitals. We were always able to handle it. It wasn't like it was in some other parts of the world. We have lots of excess hospital capacity. I think we saw that. It stretched us for sure. We had to slow down surgery sometimes, and no question they caused problems. But we're not seeing anything near that at this point, even though there's lots of COVID all around. So I think, lockdowns were a bad idea, and there's lots of consequences to that. And I think, you've seen the economic, political, educational ramifications of the lockdowns. And I think those things we need to really apologize for, or at least study significantly and see if it was worth the cost. And I suspect most of the time it's not. We'll talk about vaccines. This is a hard one because I don't think there's much question that vaccination or prior exposure, creation of an immunologic response in your body is beneficial to you to fight off the virus or to not get as sick. I know people they contend that it's not the case and that people still got just sick from virus. I find that pretty dubious when those reports. So I don't think that's very credible. But I think it's important to recognize that once you have formed those T cells, long-term T cells, that you're going to have as robust an immune response as you're going to have to this virus. Maybe if you get far enough out where you're not exposed to coronavirus for years and years and years, then maybe if you get exposed to it like 20 years later, then you might have been benefited from a booster. It's possible that, your body has pretty much all those T cells have died off or something like that. But I think it's pretty unlikely. And I think especially with seeing COVID now, I mean, you're seeing it spread all the time. It's hard to imagine people being able to avoid SARS-CoV-2 or one of its variants for more than a few years. I mean, I think you're just going to always be running into it. So if that's the case, I don't know. I don't really understand the concern with having, boosters. Probably for people who are older, people who are immunocompromised, who don't have as good an immune response, it makes sense that it might be a 3 or 4 shot vaccine series, and that may be a better way of looking at it than a booster for someone who's 80. But at some point, you either have the immune response, or you have the immune sort of coverage protection, or you don't. And so I don't know exactly what the point is of doing further boosting. Maybe someone will come on here and convince me otherwise, but the data for the booster is, I think, not great. Probably for people who are older, again, if making it like a 3 vaccine series, it makes sense. But beyond that, I don't quite understand the point of it. Even right now, you're giving a bivalent booster showing with half the original, and then you're getting some other, again, Omicron and Delta strains that are pretty much gone now. You have other strains, so I'm not quite sure what the rationale is behind this, except that Pfizer wants to make some money and Moderna. Again, someone convinced me otherwise, but there have been no randomized controlled trials showing that there's huge efficacy of this sort of thing. They've certainly not shown an efficacy for preventing, certainly doesn't prevent transmission. And so one of the hopes is with a vaccine that you're going to prevent transmission. That hasn't happened. There's clearly, it may slow transmission slightly, but not enough to make it much of an impact. So if that's the case, then a mandate for a vaccine makes really no sense. It may be prudent for you to get vaccinated. And so that's the next question. Is it prudent for you? If it doesn't actually slow spread, we can't mandate it because me getting a vaccine doesn't keep you safe, right? So if that's the case, then does you getting a vaccine keep you safe? Well, maybe. Probably once you've been vaccinated or had infection or something like that and have that T cell formation, then you're probably as protected as you're going to get, as far as we can tell. There's certainly not any really good data showing that something that is extremely unlikely event, like a very small child having a bad reaction to SARS-CoV-2, ending up in the hospital or getting MIS-C or something like that, that the vaccine prevents that. And the reason you can't show that is because you have to have, for something that's very, very rare, to show that a therapeutic intervention is useful, you have to have a really large study. If it was something super obvious, like the polio vaccine, well, then it doesn't take as many kids. I mean, polio vaccine still had large trials to prove it, because paralysis is a really bad, big problem. But you don't need as many people getting infected, kids, to show that there's a benefit to it. So you have to have for something that's very low likely event, you have to have a very large sample size, and that just hasn't been done. I mean, to my knowledge, there's not a good study showing that the vaccine or the booster significantly reduces the chance of severe disease in children. Now, as you move on in age, it becomes more obvious that it's useful. And so there's no question that having immune protection will keep you out of the hospital more. I think that's pretty clearly been proven. I feel fairly confident with that. There's also, of course, and if you have an intervention that has not shown to be a huge benefit, then you have to recognize that there are potential adverse events. Myocarditis is certainly a signal that's been seen in young men or boys. It's like adolescent boys to like the 20s. And so the notion of mandating something like that, and this is where I have a real problem with colleges right now, is they're mandating not only the vaccine series, which, again, if you've had it, I don't know if you're 22, why you need to really get vaccinated. You can if you want. It's not medical advice. You can do what you want. But I think the question of the benefit of it has not been clearly pointed out, I guess, in the studies for people who are teenagers or 20-year-olds, again, because they're usually not getting that sick. And so you have to have a large sample size, which they did not do for a lot of the studies because there's emergency authorization. So is a booster, is it going to be highly advantageous? Maybe. And I think that's a decision for you to make as a parent or as a young adult. But I think that should be a decision that you make. It's not something that should be made for you by your university saying you can't get your degree, you're going to get kicked out of school or something like that. I think these are unreasonable sort of things, because especially since the vaccine, the booster, benefits you. It's your decision, right? Autonomy is one of the 4 foundational bases of our medical ethics, and so you have to have autonomy with your body. And so I don't understand why this is so challenging. I get it that we were hoping that the vaccine prevented spread, but it doesn't. So whether people are vaccinated or not is not really going to protect people who are unvaccinated, who are walking around, or people who are vaccinated walking around who might be immunocompromised. I'm not sure. And again, we have to recognize there is a safety signal. Anytime you do something, even if it has no effect, well, you have to say, well, then why are you making an intervention? You first, at a minimum, maybe you're making someone's arm sore, or you're making them miss work. There's some sort of cost to this. There's time involved. There's resource involved. And so just do something because you think, well, it might be a good idea. You have to show some sort of benefit. You can't have an intervention of any sort that you can't mandate. That doesn't actually have any proven benefit. Now, everybody has to make the decision of whether it's worth doing something or not. And those are decisions that the patient should make in consultation with their physician. The notion that they don't have this choice, that there's some sort of greater, societal good, I don't see. Maybe I'm wrong. I definitely open up the possibility that I'm really wrong here. But if there is a benefit to it, it's very small, and it's one that I think, that from a society standpoint, I'm not quite sure what it is. If you think it's really changing the transmission rate, which is the only thing I could think that you would think is worthwhile, but even then, it's not stopping the vaccine or the virus in its tracks. So it's hard to, make that argument. And I think the biggest problem with the mandates and with the vaccines, and with a vaccine that clearly for kids is not keeping, there weren't scores of kids in the hospital from COVID. There were some, no question. And it's tragedy. I've lost a child. I know what it's awful. It's terrible. And I get it. But these are decisions that should be made by the family, because we've seen that if you're vaccinated or not vaccinated, your ability to transmit to others is probably not that different. So you're not stopping the transmission of this virus. It's still moving around. And so we can't just rely on mandates to prevent this thing, because that's not what's going to stop the virus. Nothing's going to stop it. There are animal species. Deer get infected with it and can transmit it. There are multiple animal reservoirs. So we can never eradicate SARS-CoV-2. It's always going to be with us. It's always going to be something affecting us. So what it's going to cause, though, is it's causing problems with other vaccines and other vaccine hesitancy of things we know that are very preventable. Problems like polio. We've pretty much eradicated polio, yet now the incidents they're seeing polio in like the sewage system in a number of metropolitan cities, and that's a fecal oral transmission. That is a virus that if there's a lot of kids who are suddenly not vaccinated, we're going to see outbreaks of these things that we thought we had eradicated or pretty much eliminated, because different viruses respond differently to vaccines. Polio is not coronavirus. It's not influenza. It's a different type of virus, right? And so the vaccines have different efficacy. They work different ways. They're more effective or less effective. But my real concern here is not only have you with this pushing this vaccine that is, it works, but it works in its own way. It doesn't prevent transmission. So if you're telling people that it is, and it's not clearly not preventing transmission, they're going to think you're lying about everything else about it. That's an entirely reasonable sort of response to it. It ruins your credibility. And the problem, of course, is that now they're going to not trust you about all the other things that we know work. And so all these other childhood diseases that we've pretty much wiped out, like I've never seen H. flu B, or Hib, where you have the swollen epiglottis and epiglottitis and a kid who can't breathe, who's can asphyxiate. I haven't seen it because it pretty much has been eradicated thanks to vaccinations. Well, that may go away because people are stopped vaccinating, and then now we're going to have an outbreak of that again. That makes me, angry that public health officials who have pushed this vaccine and made, I think, outrageous claims of what it can do, or at least exaggerated claims of what it could do. That's probably a better way of putting it. They said it could do certain things. And since they continue to push the narrative that it can do these things, which we know by now, everybody knows that it doesn't do, that now people are going to distrust other things that the medical professionals are going to recommend. I feel for pediatricians, they're going to try and push these vaccines that they know prevent serious childhood morbidity, mortality, deafness, certainly death, ICU stays, respiratory problems, paralysis. They're going to continue trying to encourage the patients to get these things, and they're going to get refused by patients and their parents, because they're like, well, the last time the establishment told me, or the medical industry told me about this, they were lying. So why would I believe you now? There's already hesitancy before about putting, impure things in, and concerns about autism, all these sorts of things which have been pretty thoroughly disproven. But even if they weren't disproven, I mean, there are a large percentage of people who are not going to believe the physicians on this, or, whatever, the public health people. And you're not going to get them back. It's not like this is something like, oh, oops, our bad. Go back to getting all the regular stuff. We're changing our mind about the COVID vaccine, which, by the way, they haven't given up. They're still pushing it. If that was the case, people still aren't going to come back. Because once someone's lied to you or misinformed you a couple times, you're not going to just suddenly start believing them again all right away. It takes years to get that trust back, if you ever do get it back. And the more you seem political and the more sort of authoritarian approach or top-down approach you use to try and convince people to do things, the more they're going to resist. I think, maybe more so in this country because of, our history of being sort of individualistic, or, believing in sort of our, doing things on our own. I don't know. So anyway, I think it's important to recognize that there's some serious problems there. And I don't know how to fix it. I wish I could tell you why, but I think it's a real problem, and it's something we need to start addressing right away, because the more we push things that are clearly not true or are exaggerations, I think we're going to pay for it as a medical profession, as a country, pretty easily. Then I just want to briefly touch on antivirals, Paxlovid, ivermectin, vitamin D. I think, I've done an episode on vitamin D. I've not done one on ivermectin. I didn't find any of the evidence very compelling. People had made comments about Pepsid as being Tagamet being one, that cimetidine, I should say, that'd be useful against COVID. People have tried other things too. And I guess I would say that much as I find the people who insist that every sort of problem in society now, or, well, I guess I'll say this. When it comes to the charlatans in the world, there are plenty of people in the anti-COVID or the COVID minimalist, we'll call it, camp, who claim every single death that happens on a football field or any sort of medical problem, well, clearly it's because everyone's vaccinated. There's no other possible explanation. Or that there are more excess deaths that we know are not attributed to COVID, because, we can look at, see which ones are related to COVID specifically, like causing, pneumonia, COVID pneumonia. No question lots of people died from COVID. I don't think there's really any dispute about that. Some people will, but for the most part, I think it's indisputable. But there are other reasons. There's a lot of excess deaths that are not attributed to COVID. Well, the reason for that is maybe the vaccine. I doubt it. It's possible, but there are scores of different reasons that people could have. There could be excess deaths. Maybe you've delayed medical care that you would ordinarily not have delayed. Maybe everybody delays their going to see the oncologist for cancer by a month or 2 months. Maybe it's because of COVID policies, possibly because things are locked down, or just because they're hesitant to go in, or they're doing other things, or they don't trust doctors as much, and so they wait a little bit longer. All those things alone could increase the chance of you getting to the cancer too late, let's say, or getting that heart cath that you needed. Now you've gotten serious heart problems, or you've got some serious blockage that's caused coronary ischemia or something like that. There's possibly that because of the social isolation, that there's more depression and more anxiety, and that's caused a problem with your health, which we know that your mental health actually affects your physical health, but also maybe it affects your more suicides or more other dangerous behavior, and so you're more likely in trauma. There are all kinds of reasons. I would think that the likelihood of the vaccine causing this, I think, is pretty low. Does the vaccine cause some problems with blood clotting and things like that? Well, we know it does a little bit. Does it on the micro level that we're not paying attention to? Maybe. I don't know. So it's possible. It's one component. But I think the people who say, well, for sure it's because of the vaccine. I mean, otherwise we never had these things happen. Well, I don't know. I'll be the first one to say I'm not sure if people were dropping on the football pitch, as they say in England, before. Maybe. I don't know. I can't say. I mean, now with social media, everyone's focused on it, and I see posts and people like clearly making the inference that it's because of the vaccination that's causing these things. I find it hard to believe, but it's possible. I won't deny that it's a possibility. But I think, when it comes to Paxlovid, you had a medication that was pushed that is an antiviral, much like Tamiflu was for the influenza. You have to give it within a certain window. It was only tested on people who are unvaccinated, which or had not had previous exposure to COVID, which at this point, I don't know how many people that is. That can't be more than like 5% of the American population that hasn't had COVID or been vaccinated. And so if that's the case, I don't know. I mean, you think you need to run new studies to see if Paxlovid works, because we've seen plenty of data and anecdotal evidence of people who have rebound and problems with Paxlovid afterwards. I think a lot of these things, and this is one of the problems with the FDA and the CDC, this is a problem that existed far before COVID, that there's a revolving door between industry and the regulatory bodies. And so there's an incentive, if you're a regulator, to maybe, push these medications or allow them, or say that they don't really need to finish the studies completely, or maybe, and because you're going to get your next job in that industry. So, it'll be interesting to see how many people end up on these boards afterwards for these pharmaceutical companies. We've already seen Scott Gottlieb, who is a former FDA commissioner, I think it's FDA, who is now like on, I think, Pfizer's board or something like that. So I don't know. That doesn't seem like a very, it certainly seems like a conflict of interest, right? Now you may not have a conflict of interest right now, but if you think, oh, well, I know in 5 years I'll be able to say, well, I worked at FDA. Why don't you let me on your board and I'll make 6-7 figures at your pharmaceutical company? That's what congressmen do. We know that. We know they go work for lobbyists and they work for various industries. So I don't know. I mean, I have a hard time accepting the fact that these medications are accepted or approved on these sort of, I think, fishy, at least the efficacy is certainly of question, and the emergency use authorization is fine, but you have to, if you're going to authorize something on an emergency basis, that's fine. But you have to then at some point say, we have to be, as soon as we authorize it, we're going to have studies and study this. We're going to have multiple investigators, multiple studies, not just one, so that we can, if we have 3 that are all positive, then we know that it actually works versus just one study. We have to do that. I don't see any way, this idea that we can just, something's such an emergency, we don't have time to figure out the answer to it. You wouldn't do anything that's like that in life, right? I just can't imagine that you're just going to go out about your business and say, well, I'm just going to keep driving. I know my tank says E, but I know I can go a little bit further. And then I'm never going to actually, once I get to my destination, I won't check to see how many more miles I could have driven. Right? I mean, you want to try and figure things out so that later it's useful to you. It's useful knowledge. Like, I can always drive 10 miles beyond when my car fuel gauge says empty. Maybe it's 15. Maybe it's like 1. Those are things you need to know. And so just like that with these medications or with vaccines or with wearing masks, these interventions, you have to actually study them. And to not study them is, I think, a real problem. Yes, there are certainly problems with evidence-based medicine in the generalizability of some sort of condition, where you say, oh, well, because we're doing X, then we know that Y will happen. Well, that only assumes that the person you are studying is exactly like the person who is going to be getting the intervention later, right? So we've had this all the time in medicine. We do this all the time, which is a problem. I think the beta blocker study is a really great example where we said perioperative, around surgery, you should have beta blockers and we should continue it. And then it became, well, that was a certain subset of patients who had a history of cardiac disease. And then you expand it to saying, well, someone's on a beta blocker, they should continue it. Okay. And then it's like, well, if you have maybe real mild hypertension, or maybe not even really, but you're 65, maybe you should go on a beta blocker and start that before you have surgery, and then just, have it stay on it for 2 to 4 weeks afterwards. We started making assumptions that saying these people were just like the people in the original study. And what happened, of course, we look at more from a long-term standpoint, we find that we cause more harm than we thought. And so we just have to be, aware of these possibilities. We can't just be so cavalier about it. And, you can be cavalier in your own life or how you drive. If you want to drive, how you live. If you want to go rock climbing without any harnesses, well, you're the one accepting the risk for that, I suppose. But we can't just go about and just from a public advocacy or, if you have regulatory bodies, you can't just be cavalier about these things. You have to say, we have to know the answer or do our best to find the answer. We can't just say, well, best of luck to you. It's real important we do this, but never actually study it and follow up, make sure that you did the right thing so that the next time something happens, you can actually have a history so you know what's going on. Well, I think I'm going to turn off there, and I appreciate the comments from people here. I think I just had to get it off my chest. I think it's time so I guess in summary, right? SARS-CoV-2 is here for the rest of our life. You're going to get infected multiple times, so you can't avoid it. You can avoid it for a little while. If you're super careful and you avoid people I guess you can avoid it for a long time. If you want to be a hermit living in the woods, although you have to avoid the deer because the deer have it. If you want to wear a mask the rest of your life, I guess you can, but there are trade-offs for that. One is you're not going to be, as interesting you'll be hard to understand, and, it's uncomfortable. Anyone who tries to do anything serious, with a mask on for a long period of N95, it's really uncomfortable. I mean, you can do it, but you can do anything, but to wear N95 is, I think, unreasonable all the time. And I guess one thing I would mention too, the immunocompromised is a good question, because people say, well, you can't be so cavalier about not wearing masks or, not getting vaccinated, et cetera, because you might have SARS-CoV-2 and you give it to somebody who's immunocompromised. And that is true. And so that's why, again, in the hospital, if someone's immunocompromised and they're at a threat from being hurt, you absolutely want to make sure that they're protected. But you have to make sure that if you are someone who is immunocompromised all the time, right? If you had a solid organ transplant, you didn't get the solid organ transplant so that you could live in bubble wrap the rest of your life. Yes, you need to be careful. Yes, you need to take precautions. Do you live in a house full of mold? Probably not, right? You don't you don't go looking for trouble, but you also have to live life too. And it's not fair to expect the rest of the world to bend to your special needs. That's not callous. That's not selfish. That's just a recognition that if you are someone who has a certain condition, you have to go about your way to protect yourself. Yes, it's reasonable for society to have accommodations for you. Like, for instance, let's say you're stuck in a wheelchair. Well, as long as we make it so you can get in and out of places, I think that's a reasonable accommodation from the public. The expectation that everyone has to have everything so that you can do whatever you want is, I think, an unreasonable accommodation. I mean, it'd be nice if people could, but sometimes it's just too expensive or you can't do it. So if you're someone who has a short-term problem, like let's say you got a bone marrow transplant, you've got to, while you wait for your immune system, your blood cells to sort of, arrive, you've got to wait a certain period of time. Well, then it's reasonable to do everything you can to avoid contact with people for 6 months or 6 weeks or so with an N95. That's a reasonable thing you can do. But if you're always immunocompromised, it's unreasonable for you to expect everyone else to do everything, to live in fear and to do everything they can to prevent getting you sick when basically you've got some sort of condition and there's just no way that it can be fixed. I don't think of myself as a callous person. I recognize that there are some problems, but we've got asked soon after this sort of COVID hit, when you had the immunocompromised, we had a child with us who had a solid organ transplant. The question was, are you going to protect him, keep him out of the way? And we're like, the reason he got it is so that he could live life. Yes, he's at higher risk for things happening, but you're at high risk for all sorts of things happening all the time. So I think, he can make the decision on how he wants to live his life, but it's up to him. It's not up to me. And so I think we have to recognize that if you're someone who's worried about it, then you have to extract yourself from places you think are high risk. But it's not reasonable to expect everyone else to behave in extraordinary measures in order to protect you. And I would say there are consequences for acting that way for everyone. Let's take one quick example. If everyone walking around you when you walked into a town was wearing a hazmat suit, would you feel comfortable in that place or uncomfortable? If you had people always walking around with a machine gun strapped over their shoulder, right? And they're just walking around, no, just normal. Is that going to make you feel comfortable or uncomfortable? Are you going to maybe have some anxiety? I mean, imagine what we've done to our society, that we're always living with the threat of some sort of big thing. And so I think, masks are a minor thing, but I think they're not minor in the sense that if everyone's wearing a mask, something's wrong. It's not normal, right? And so there is a cost to that. I don't know what the cost is. Maybe a little bit more anxiety, maybe more depression, fear, whatever. Aside from just the cost of it, the actual expense and then, the waste problem. So there is a cost to that. And so these are the things that people who are elected leaders are supposed to make the trade-offs for. Do you mandate the vaccine? Well, does it do what you think it does? Does it stop transmission? If not, then really what are you mandating? Right. So these are the questions that need to be asked. And these are things that have not been asked. They've not been discussed. They've not been debated. And that's where there's so much anger and sort of problems with this whole COVID fiasco, I'll say at this point. So we need to have rational approach to masking, where basically probably just need a mask in places where people are at high risk for, someone who's got active infection that you need to protect yourself, or and also you probably need to, as far as it comes to COVID-19, I think there's no reason to have any mandate for vaccination because you're not protecting other people with your vaccine. It's for their own good, if you think, and that's why you can make the argument for why they should or shouldn't get it. But that should be a bodily autonomy question for those people. That's, again, one of the bases of medical ethics. Then also, when it comes to science and discussion, and I think we just need to have a rational policy. We need to actually think about things. We need to talk about things. We need to have open discussion. People need to come to me and say, you're totally wrong, and explain why. I can go up to them and say, you're totally wrong. Let me explain why. And to say that without retribution and to be silenced or fired or whatever, those just aren't helpful. It's not like people are going around and saying like drinking bleach or, that's a healthy thing to do. Please do that. That'd be like crazy misinformation, and that someone should be, they should be silenced for that, for sure. Right. Because we know that's absolutely 100% wrong. Jumping out of airplanes without a parachute, that's a bad idea. Unless of course the plane's on the ground, right? That'd be the dad sort of riddle there. Those are things that we can chastise people for. Again, I don't know that you'd fire someone. You'd say, well, you're exhibiting some poor judgment there. Because if we get rid of debate, especially in things that are not known, and a brand new virus, clearly nothing was known. I understand that you felt like there's a need for someone to do something. I understand why I think we got where we did, but ultimately we need to be more thoughtful about how we approach things. We need to have public officials that actually weigh the pros and cons of any sort of measure. And we need to just get back to being ourselves and being human. And that's been my biggest struggle with this, because although I was able to go to a job and have physical and have personal interactions with people, which was great during the pandemic, I'm also still now sort of limited. I haven't really advanced. Everyone else is kind of going back to normal. They go to work, they see people. Everywhere else we go in society, you don't have to have masks. You have normal interactions. But at work, I'm not allowed to. And it's a problem. And I don't know. I wish it wasn't the case. And I wish the government would sort of fix that, because they're the ones who broke it. And so anyway, that's a kind of long rant. Hopefully it was helpful and useful to you and you found it entertaining. Make sure you like and subscribe to the show. If you, I will try and come up with more stuff. It's not going to be COVID the next few things. It's going to be some other stuff involved with healthcare. I'm pretty much over COVID. I think I've now gotten out of my system, hopefully. And hopefully nothing else weird happens with COVID, because then we can just stop talking about it forever, which would be great. So anyway, until next time, I'll talk to you later.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.